Hello, my name is Rebecca Leff, and I'm a fourth-year medical student at Ben Gurion University in southern Israel, and I'm here today to present our research, Limited English Proficiency as a Barrier to Inclusion in Stroke-Specific Emergency Medicine Research, on behalf of our research team. We have no disclosures. Approximately 8% of the US population, roughly 25 million people, can be described as having limited English proficiency. Limited English proficiency describes an individual over the age of 5 who speaks English less than very well, as self-reported to the US Census Bureau. Limited English proficiency is an independent risk factor for both poor healthcare access and outcomes in the United States. In fact, patients who report limited English deficiency also report less satisfaction with their healthcare and lower likelihood of returning to receive healthcare services than those with better English proficiency in several studies. Due to challenges accessing care, the emergency department is the point of entry to the healthcare system for many limited English proficiency patients. Emergency medicine research is supposed to be broad and inclusive to all the patients we see in the ED. But are limited English proficiency patients included in emergency medicine research? Is the research body that we have in emergency medicine applicable to this population? So to understand that, we set out to evaluate the inclusion of language in emergency medicine-based clinical research on stroke, because it's a common ED presentation and leading cause of mortality and morbidity in the United States. We conducted a systematic search in Medline, Embase, and Cochrane databases, using US-based publications from 2015 to 2020, using key search terms for stroke and emergency care. Data were extracted using an a priori determined standardized reporting tool to evaluate language as study inclusion-exclusion criteria, manuscript reporting of language, assessment of language as a primary variable, and consideration of language proficiency in study methodology. Continuous and categorical study characteristics and primary study outcomes were evaluated using frequencies, percentages, and 95% confidence intervals. Overall, 167 studies were included, and we followed PRISMA guidelines. So of those 167 studies, 22 studies noted whether they used language as an inclusion or exclusion criteria in either the manuscript or the documentation for the dataset registry used for the study. 14 studies explicitly indicated whether language was used as an inclusion or exclusion criteria within the actual manuscript text itself, so regardless of the dataset registry. And 17 studies allowed low English proficiency patients to participate based on either the manuscript or the documentation for the dataset registry. And 5 studies explicitly excluded patients with low English proficiency, and the remainder of the studies did not comment on language as an inclusion or exclusion variable whatsoever. So of those 17 studies which explicitly included patients with limited English proficiency, it's important to realize that actually only 3 of those studies included speakers of other languages, and the majority, 82.4%, only included English and Spanish speakers. Additionally important is that 66 studies used data from an existing data set. Of these, only 1 data set explicitly included limited English proficiency patients. And this data set was the FAST-MAG trial, which included English and Spanish-speaking patients, but excluded speakers of other languages. The FAST-MAG clinical trial data set was actually used in 10 other studies, which shows the power of one study, including limited English proficiency patients in their inclusion criteria in order to sort of overall affect the emergency medicine research for stroke. Studies were further evaluated to determine how language was specifically utilized. Language was mentioned in only 14% of studies in the primary analyses or demographic analyses. 9 studies accounted for language in the methodology, and only 4 studies included language as a primary variable. 4. So what do we get from this? What I think we get from this is that emergency department studies specific to stroke care in the United States routinely do not account for patients with limited English proficiency, and in some cases specifically exclude them, which makes it hard to include the body of emergency medicine research and apply it to this population when we're working in the emergency department. Few studies included language as a variable when evaluating outcomes. And this is important because the inclusion of limited English proficiency patients in emergency medicine research is critical to understand disease prevalence, appropriateness of treatments, and health outcomes for this population. So today I'm speaking to you all as academic emergency physicians. You have the power, you have an opportunity to engage in language inclusive research when you conduct your next study. Practices that will lead to a better understanding of disease prevalence, presentation, management, and outcomes for patients with limited English proficiency, with help from funding agencies, journal editors, institutions, institutional IRBs, and again, you as an individual research or research team can think about limited English proficiency patients when you go to conduct your next study. Thank you so much for your attention, and I hope that you consider limited English proficiency patients as you go to connect your next study. Thank you.
Hi, I'm Taylor Stavely. I'm a PGY3 at Emory Emergency Medicine. I'm excited to share my work with you on professional development and gender identity among women emergency medicine residents. Since we're doing this 2D, I thought I'd give you a cartoon of me and my co-residents. That's me on the far right. I have no disclosures to report. Background into this work, we found that as women enter the field of medicine more and more, and we've been entering at similar rates as men since the 1980s, there's been much that's been revealed about the gendered politics of women in medicine. Women are required to negotiate conflicting gender normative roles with the work that they do as physicians. There's not much really known as to how gender identity affects the professional development of residents specifically. In order to go about this, we performed qualitative semi-structured interviews at Emory. We elicited volunteers by sending out emails through our listserv, and we conducted interviews on a virtual platform, recorded the interviews, and then had the interviews transcribed by a professional transcription company. And two of our investigators then coded the transcriptions to find salient themes. We conducted these interviews until we had reached thematic saturation, which ultimately was with 11 interviews conducted. These are the demographics of the interviewees, and you can see that there is a mix of all PGY levels at our institution, as well as a mix of different racial and ethnic identities. The results were interesting in that we found that our female residents or women identifying residents have multiple similar gender related challenges in the workplace. More than any other type of population, more than their patients, their consultants, their attendings, the group of people for which women feel they receive the most challenging or undermining of their authority or competency was actually nurses. Here are some representative quotes. One resident states, "After a difficult interaction with a nurse, I cannot help but think sometimes maybe this had to do with my gender." Another resident comments on running resuscitations and that their decisions are not always well received, and that she's noted that men don't have that same issue necessarily. Another resident comments that it's a very difficult balance of I want to be respected, but I don't want to be bossy. I want to be nice, but I want to be taken seriously. It's kind of hard. I agree, it is kind of hard. And it really highlights that women have this conflict between traditional gender roles and then the position of authority and leadership that they must take on in order to be effective emergency medicine physicians. Another common theme is that women have very similar strategies to employ whenever they feel like their competency is being undermined. And that strategy was that they over explain or really feel like they have to go into detail into their thought process and their decision making. This resident comments, "With nurses, it's a very different bond. I'm always trying to be super nice. And if they question anything, sometimes I feel like I really have to explain, sometimes over explain." So whenever a resident puts forth a plan or an order, if that is challenged, they feel the need to go into great depths about why they're making the choices that they make. And our residents commented that they don't feel like they've had to see their male counterparts go into so much depth in order to accomplish the same tasks. Another theme was the ability of race concordance to actually really facilitate patient interactions. At our site, we train mostly at Grady Memorial Hospital, which is a safety net county hospital in the Atlanta, Georgia area. And our residents who identified as Black or even racially ambiguous felt that their race actually really helped them develop relationships with their patients and provide better patient care. One resident felt that their background was their greatest strength and that their diverse background actually gave them a better ability to relate to different patients. And for me, that really highlights why diversity in medicine is so critically important. The second quote, this resident says, in some ways, just simply by the color of my skin and the fact that I could look like multiple ethnicities, when we do get patients who are ethnic minorities, they automatically trust me or feel more comfortable with me and being in my care. And I really love how this resident is able to develop important rapport and relationships with her patients who perhaps in the past have been treated unjustly by the medical system. Another result was kind of the need for an intervention and where is it that we go from here? And overwhelmingly, our residents really felt like they wish their male colleagues had some idea of what it is that they go through on a daily basis and the need for bias and ally education. This resident says, I don't think people are even cognizant of it. And so that awareness is so important. As a small side project off this research, I actually made a toolkit for allyship behaviors, and that chart on the right is taken straight from that. But ultimately, next steps would really include a more intentional and thoughtful programming on gender and racial bias education for residents and attendings in medicine. In conclusion, women actively negotiate these tensions between their gender and their role as physicians. They have multiple strategies in place to try and overcome these challenges. And in addition to gender, race and ethnicity was a very important contributor into their experience as a physician. At this time, I would love to take any questions or feedback. Thank you.
Hello, my name is Sam Parnell. I'm an assistant professor of emergency medicine at UT Southwestern Medical Center in Dallas, Texas. Hence the Dallas skyline here is my virtual background. Thank you for attending my Lightning World presentation today. We're going to be going quite fast, hence lightning in the name. We're going to be discussing operational processes to reduce inequities of care in the evaluation of chest pain. I have no conflicts of interest and no significant disclosures. And I'd like to start with a shout out and a thank you to the A-Team, the group of individuals who allowed this project to be a success. Dr. Sam McDonald, who has a background in bioinformatics, Dr. Deborah Dierks, who is our chair and an expert clinician researcher and has a specific interest in cardiopulmonary pathology, Dr. Mark Courtney, who is our executive vice chair, who also is a prolific clinician researcher and is a specialist in cardiopulmonary disease, Mike Mayo, who is our nursing medical director, and Rachel Fadley, who is our nursing manager. Thank you for all of their contributions to this project. So for background, multiple studies have shown that healthcare disparities exist in the diagnosis and management of acute coronary syndrome, as well as other syndromes encountered frequently in the emergency department. And our question was, do standardized triage processes and protocols and a provider in triage reduce these inequities of care? Our objective was to evaluate the differences in the prevalence and timeliness of ECG and troponin testing based on sex, race, and language spoken for patients who presented to the ED with chest pain to see if there was a significant difference that could affect clinical outcomes. So this was a retrospective single-center study at Clements University Hospital in Dallas, Texas. This center had a provider in triage and standardized chest pain diagnostic protocols and order sets for both ECG and troponin testing. And there's a photo of Clements University Hospital on the slide. The primary outcomes were arrival time to ECG and troponin order entry, stratified by sex, race, and language. Inclusion criteria were adults greater than 18 years of age who presented to the ED with chief complaint of chest pain, and the study period was 20 months from January 2019 to August 2020. For analysis, we used Wilcoxon rank sum tests to compare subgroups, and we also used regression models that were fit regressing troponin and ECG order entry based on sex, race, language, and age. Here are some of the demographics and results of the study. So the study included about 5,000 patients. 58% were female, 42% were male. Almost 95% spoke English. For age breakdown, about a quarter of the patients were older than 65. About 40% were between the ages of 65 and 45, and almost 36% were less than 45 years old. 99.1%, so almost 100% of patients had an ECG order placed, and 89.7% of patients, or almost 90% of patients, had a troponin order placed. Here's the distribution for race and ethnicity. So 42% of patients identified as Black, 32% of patients were white non-Hispanic, 14% were white Hispanic, 10% were other, and 2% were Asian. Here are the results for time to ECG order. This is shown in median minutes. So as you can see from the table, there was no clinically or statistically significant difference in time to ECG order based on sex, language, or race. And the median was around 4 minutes for all of these patients. Here are the results for time to troponin order, again listed in median minutes. As you can see from the table, there was a small but statistically significant difference in time to troponin order for females versus males. Females was 33.5 minutes versus males, which was 30 minutes. So a delay of about 3.5 minutes for females compared to males, which was small and may not be clinically significant, but was statistically significant. There was no significant difference in time to troponin order entry based on language or race. And in general, the median time to troponin order was around 30 to 35 minutes. So overall, for sex, race, and language, they were not significant predictors for ECG or troponin order. The significant predictors for troponin order were age greater than 65 years with an odds ratio of 1.9 and having an ECG order placed during the visit with an odds ratio of 24. And most patients did have an ECG order placed, but those who didn't were also unlikely to have a troponin order. There was no clinically significant difference in time to ECG or troponin order based on sex, race, or language. However, as discussed, there was a small difference in time to median troponin order entry for females, which is about 3.5 minutes slower compared to males. So the strengths of the study, it was large, had a relatively diverse patient population. It did evaluate the prevalence and the timeliness of ECG and troponin testing. The limitations were it was a small single center study. It was a retrospective study. Almost 95% of the patients spoke English. There was a very, very high prevalence of ECG and troponin testing done. So perhaps we were just over testing these patients for chest pain. And there was no comparison to the same demographic without order sets or provider and triage, which are some of our next steps. So in conclusion, we found no meaningful difference in the prevalence or timeliness of ECG and troponin testing based on sex, race, or language. And we suspect that standardized triage protocols contributed to prompt objective diagnostic evaluations for patients who presented with chest pain. Next steps, further studies are needed to determine the specific impact processes such as provider and triage and standardized order sets have on equitable diagnostic evaluations. And we need to determine if we can generalize these processes and protocols to other systems and other hospitals and other chief complaints to reduce overall inequities of care, which of course is our end goal. Thank you very much for listening. Thank you for all that you do every day taking care of patients. Here is a QR code with a link to my references. And with that, we will take any questions. Thank you again.
Good afternoon, everyone. My name is Danya Eniati, and today I'm going to be presenting my research evaluating emergency department use for laceration-related injuries among the U.S. homeless population from 2009 to 2019. I have no relevant financial disclosures. So starting off by providing a little bit of background as to why we initially performed this research. It has been estimated that over 550,000 Americans experience homelessness on any given night. And past studies have shown that unhoused individuals are 3 times more likely to visit the emergency department compared to housed individuals. Because this high-risk population has limited access to high-quality health care, the undomiciled community faces many barriers to proper wound healing. This predisposes them to higher rates of life-threatening wound infections, such as osteomyelitis or neck fash, which could lead to potentially higher rates of amputations down the line. And so the purpose of our research was to assess the characteristics of laceration-related injuries presenting to the ED among the U.S. unhoused population. Looking at our materials and methods, we performed a retrospective cross-sectional database analysis using the NICE database. We looked at a timeline from 2009 extending to 2019, and we identified patients who were classified as being undomiciled by using triage narratives that were recorded by ED staff. We evaluated several variables. The primary variable we were interested in included the trends in the incidence of ED visits for lacerations in both the general patient population as well as in the undomiciled patient population. And we used SPSS 26 for our statistical analysis. When looking at our results, we had a sample size that totaled 759,578 ED visits for lacerations. Of that number, 58 ED visits were made by undomiciled individuals. Notably, we found significant trends in lacerations presenting to the ED over the past decade. As seen in the graph on the left-hand side, in the general population, we found a significantly downtrending incidence of lacerations from 2009 to 2019. We specifically found a 25.94% reduction in the incidence of lacs over this decade. This was in steep contrast to our findings in the undomiciled population, as seen in the graph to the right, in which we found a significantly upward trending incidence of lacerations over the same 10-year period. When looking at the sampled undomiciled population, we also found that the most common sources of laceration were windows or broken window glass and fences, both of which separately accounted for 8.62% of the total lacs. When looking at the most commonly lacerated body parts in this group, number one was made up of finger lacs, making up 24.14% of total lacs. Number two were facial lacs, making up 22.41% of the share. And thirdly were hand lacs, making up 10.34%. Conclusions of our research. Rising trends in lacerations among the undomiciled population relative to decreasing trends in lacerations among the general population highlights that the undomiciled community faces significant barriers to proper wound healing. Fences and windows were the instruments involved in the majority of lacerations. Many of these injuries also happen to occur at or near homeless shelters, and these findings together support the fact that many homeless shelters today continue to have unsafe living conditions for their residents. Undomiciled individuals have competing needs for food and shelter, which can often overshadow their health needs. This contributes to poor outpatient treatment, adherence, and follow-up, and consequently increased rates of ED visits and hospitalizations. Our study had several limitations that were notable. We had a very small sample size for the patients who identified as undomiciled, and we would have benefited from using a database with a larger sample size, such as the NHA MCS. Unhoused patients were identified by searching through triage narratives. Thus, many patients who did not have housing may not have been easily identified from the NICE database if their social situation was not revealed at the time of triage, or if it was simply not recorded by the ED staff. So we wanted to take a few next steps and see what steps we could take as medical professionals to support our unhoused patients who come in seeking wound care. And ways that we can help them include working to expand access to preventive care programs, such as medical respite programs, providing them with comprehensive discharge paperwork that details proper wound care techniques and that promotes local wound care clinics. We should always be educating our patients based on their specific educational level and health literacy level. Additionally, we should support cost-efficient care. And if possible, we should always try to advocate for our patients by lobbying policymakers to improve shelter living conditions. All in all, these findings may help health professionals advocate for improved wound care education, enhanced access to healthcare, and safer living conditions for unhoused individuals. And with that, I thank you so much for your time. If you have any questions, please feel free to reach out to me. My email address is right up there on the screen. Thank you so much for your time.
Hello, this is Gender, Equity, Climate, and an Academic Emergency Department. I'm Melissa Thomas from the University of Kansas Hospital. I have no financial conflict of interest to disclose. So equity disparities in gender and other protected classes are increasingly recognized as a source of stress and dissatisfaction at work. These stressors can have negative impacts on promotion and retention of faculty. We sought to quantify and describe perceived gender disparities within an academic emergency department. We created a 54-question survey that yielded both qualitative and quantitative data. There were some general themes that emerged. 3 themes were identified in women and 1 in men. Unfortunately, the women felt undervalued, not promoted, and a lack of opportunities. The men felt burnout. Today, we wanted to look at some of the qualitative data and discuss how we used it to affect change in our department. The women provided us with a lot of feedback that was very concerning. We immediately wanted to make some changes. Some of the first feedback we got was that our ED only promotes white males. We immediately responded to that by promoting 2 women to clerkship director. A woman was added to the hospital credentialing committee, and a minority woman was added to the EM executive committee. We also engaged one of our administrative assistants to help collect and update items for academic promotion. Another point that was made was that there was no insight into the struggle of women. We therefore invited a panel of female physicians from other departments within our institution, as well as colleagues from a nearby EM program, to discuss their experience at a grand rounds. Our goal was to validate the experience of women in our department. A third point that was made, that male staff are advised of opportunities in advance. I think having a woman on the executive committee helped provide awareness to this issue. We then created the role of Vice Chair of Diversity, Equity, and Inclusion to help with recruitment for new opportunities that come about. Now, let's look at some of the qualitative data from the men. There were comments about tearing down of fellow faculty members and a lack of professionalism. To hold people accountable, we implemented 360 evaluations where faculty could anonymously provide feedback to colleagues. Support for paternal leave was also brought up by some of the men in the group. Currently, some degree of paid leave is only provided to the women in our group. This is something that we plan to look into for men in our group in the future. Lack of transparency. This is something that was echoed a lot amongst both genders in our department. We have added segments to our staff meetings highlighting production and finance. Physiologic scheduling. We continue to look into our scheduling practices. Accommodations have been made for those with sleep disorders and medical issues. Staffing numbers have affected our ability to do more at this time, but we will continue to discuss this in the future. Overall, there were some concerning issues that were brought about as a result of the survey. Our department immediately began to take steps forward and are working on best practices to improve our gender climate. We now open to questions.
Hello, everyone. My name is Dr. Christine Garuya, and I'm on faculty in the section of Global Health in the Department of Emergency Medicine at the Yale School of Medicine. Data and our access to it and our ability to leverage it to assess clinical outcomes still remains one of the greatest challenges to research in international settings. Today, I'll be talking about a study we conducted using natural language processing to leverage a large existing data set to assess sex differences in acute MI patients in Pakistan. These are my disclosures. And by way of background, cardiovascular disease represents a leading cause of global mortality with a predominance of deaths occurring in low and middle income countries. Ischemic heart disease is a leading cause of cardiovascular disease globally, also with a disproportionate burden in LMICs. And ischemic heart disease is the leading cause of death in Pakistan, surpassing common communicable diseases like lower respiratory tract infections, diarrheal illnesses, and even TB. The problem is there is a need to assess epidemiological burden, clinical presentation, and management of ischemic heart disease in Pakistan and other low and middle income countries like it in order to mitigate the effects of this burden. Natural language processing is a field or method that uses algorithms which allow machines to identify keywords and phrases in natural language corpora or bodies of text, such as unstructured written text as seen in clinical text documents or electronic medical records. And while NLP has been used effectively in high-income country settings, its use has been limited in clinical contexts in low and middle income countries. Our study aims were to validate and test a natural language processing model for extraction and assessment of clinical data on ischemic heart disease patients as indicated by those with an acute MI diagnosis at the Aga Khan University Hospital System in Pakistan. And secondarily, we wanted to test the model to identify sex-specific differences in clinical presentations and management of these patients. Our foundational hypotheses then were that we would develop a model to detect these clinical symptoms and medication prescriptions among AMI patients at an accuracy level comparable to established literature on the topic. And we would also have a descriptive aim that would assess these sex differences from the model outputs. As far as methods, our study site was the Aga Khan University Hospital, which is a leading tertiary academic hospital linked to 4 secondary hospitals in the country and with multiple international sites across the world. And we used discharge summaries from patients hospitalized at AKUH with a primary diagnosis of acute MI that have been archived since 1988. And the tool was designed for information extraction from discharge summaries that are available in PDF that have both structured and unstructured text data, including tables for procedures and medication information. The model was trained in an iterative fashion, and we used batches of 50 documents with manual validation by a study team member until an accuracy of a 0.9 or 90% F-score was achieved, and the size of training sets and level of accuracy cutoffs were chosen based on established literature. As far as results, we had a total of 5,358 discharge summaries included, and 500 charts were randomly selected for model training. We had a total of 1,769 females and 3,589 males. Their ages are shown above. As far as acute MI symptoms detected, 3,435 discharge summaries included that, and 1,923 did not, including those that presented as interhospital transfers or as critically ill patients. For discharge summaries including acute MI, medication outputs, 4,302 had medications documented and 1,056 did not. As far as differences by sex for symptomatology, chest pain and shortness of breath overall were the most common symptoms detected in 63% and 41% of patients respectively. And while men predominantly presented with chest pain and diaphoresis, women were more likely to present with shortness of breath and GI symptoms like abdominal pain, nausea, vomiting, or even weakness. Lastly, Gabarahat, a culturally specific term, best translated as a sense of doom, was detected in 3% of charts. And while no statistically significant difference was detected, we felt this finding was a highlight of our results, demonstrating the importance of context-specific, culturally sensitive terms that are unconventional but important for diagnosis. As far as prescription data, we found that women were less likely to be prescribed all 4 first-line medications, aspirin, clopidogrel, statins, and beta blockers, and there were statistically significant differences for the latter 3. In conclusion, use of NLP in IHD patients in LMICs is plausible, and diverse teams may be helpful in contributing to developing effective context-specific tools. There are clinical symptom differences by sex in Pakistani patients with acute MI and sex differences in management. In future, we hope to adopt the model for other settings, including Kenya and Uganda, and also hope that our tool can be adopted for other diseases and clinical outcomes. I would like to thank our fantastic study team. And with that, I'm happy to take any questions. Thank you.
Investigating the challenges of pregnancy and parenting while practicing emergency medicine. Our research investigated the impact that a career in emergency medicine has on pregnancy and family planning decisions. Our nationwide survey was adapted from a family planning study used in cardiology. These questions were tailored to meet the specific needs of emergency medicine. It was approved for distribution by the Society of Academic Emergency Medicine and sent out to EM physicians from that listserv. This was a novel study in that it captured the experiences of both female and male physicians, while most studies in this area focuses on the experience of the woman. There were 319 respondents to our survey, majority of which were female. And of those that responded, many had children in their medical residency and early career stage, which was defined as less than 7 years into attending practice. Some limitations of this survey included the fact that it was a voluntary survey. and that the responding population could be skewed towards those particularly interested in pregnancy issues. Another limitation was the fact that it was sent out right before the pandemic and multiple times during the pandemic, which could have affected the response rate. Our survey covered three major areas: preconception, pregnancy, and parenting. The majority of women in the national study indicated that they had been pregnant in the past. Of these, 19% reported using assistive means to achieve pregnancy. This is clearly different than a general US population, which is just 1.9%. And this may not be surprising considering many female physicians delay childbearing. Of the 81 respondents who chose not to become pregnant, 69% were influenced by career, and some of the factors that were relevant to their family planning decision-making was time constraints, work-life balance concerns, work hour concerns, and occupational exposure concerns. In spite of all this, 62% did intend to become pregnant at some point in their career. When we asked survey respondents about complications, which included those listed on the right, 58% had complications with at least one pregnancy. We found that pregnancy complications occur more often in female EM physicians than partners of their male colleagues and other physician specialties. Our study highlighted safety concerns in pregnant physicians. In the emergency department, ED staff are subject to physical violence and aggression, which is often underreported and underestimated. 37% of EM physicians were concerned about physical safety during their pregnancy, and 9% reported experiencing some form of physical violence. Another safety area we looked at was radiation safety. Our data showed that 58% of physicians were unaware if their department had an official policy regarding radiation exposure during pregnancy. 76% of pregnant physicians took some form of protective measure against radiation, such as maintaining increased distance from radiation sources, lead protection, and using a fetal radiation badge. Shift work, rotating shifts, night shifts, and longer hours have been theorized to cause fatigue, disrupt the circadian rhythm, and decrease melatonin production, which negatively impacts pregnancy health and increases the risk for complications such as preterm delivery, small for gestational age, and preeclampsia. Night shifts have been associated with miscarriage as well, especially in women who work more than 2 night shifts per week, and that risk rises as the number and frequency of night shifts increases. In our study, we found that 63% of pregnant EM physicians work night shifts, with only 16% reducing the number of night shifts, which is a stark contrast. And as you can see here, beyond 36 weeks of pregnancy, over half of pregnant EM physicians continue working night shifts. Our study demonstrated that both male and female EM physicians took less parental leave than available, with a significant proportion of males taking less than 1 month. Most women took 12 weeks or less, and reasons for this included feeling pressure to shorten their desired leave, feeling like an increased burden on colleagues, lack of desire to extend training, and financial concerns. The last area we looked at was lactation. In our study, 82% of physicians were either unsure or said their institution did not have a formal policy on pumping during the workday. Nearly all female physicians intended to breastfeed, but that actual rate dropped from 97% to 65% beyond 6 months. We identified the barriers on the right as reasons that women were unable to achieve their breastfeeding goals. So we have identified challenges in the preconception, pregnancy, and early parenthood phase with this study. And we're hoping that with this information, we can create new policies and best practice recommendations so we can better support our EM physician parents.